All right, so today is a special occasion because we're going to have someone who's never been here talking to us before. And this is particularly important to me and Matt because it just tells a story of probably, I mean, I can speak for myself, but I believe Matt also feels the same way. Today is about building your dream, basically. That's how I see this. It started as a private lecture where it was Rebecca, Lee, Matt, the hygienist, like everything that you see here. There's a lot that happens behind the scenes, and when it's here, it's because it's been processed really well. So when I saw that lecture, it kind of just reassured that my decisions, our decisions to be in this practice were right, were for the right reasons. So it's about how to build a practice that you're proud of, how to build a place where you want to go to work. I don't call it, well, I call it work because I love working. So, but a lot of people think that's a four-letter word that shouldn't be used, but I call it work. And it's all about you, and I think that's what Dr. Sheldon's going to show. How over the years you can build a program that's different, that's unique, and that helps patients, and that's the ultimate goal, to make sure that the patients get the best of what we have. That's why we trained. It's all about people and systems, and when you get those together, this is the result. So what started as a lecture or a talk where we're going to see what could be done, what was done in the past, and what would you change or not, which way we're going forward, kind of became a purpose lecture, a discussion of how we were 43 years ago, 40 years ago, and how we are now. So, and we say we because I feel like part of the practice now. So, Dr. Sheldon will start from here.
Thank you, Dr. Furtado. I should be calling you Dr. Araujo. But there are a lot of things that happened in the past 40 years, and some of you came on only the past 2 or 3. Some of you came in even in the past 20, but you don't know the whole story. But Rebecca does know the whole story, and so thank you. I'm going to begin by where I was when we began treatment. And the beginning of treatment was you would scale and you would root plane and then you'd reevaluate and then you'd do gum surgery. That was the way periodontal practice was, and that's the way periodontal practice is. And there's nothing wrong with that, and I'm going to show you why that's actually a good treatment to do. But there was a guy that I met through another lecture, and that's Dr. Perry Ratcliffe. He was a periodontist, president of the American Academy of Periodontology in 1970, and you know him because he created this product. So I met Perry, and Perry said, I can do periodontal treatment non-surgically, and I've got a unique way of doing it. And he showed us at the lecture. And I said, I think I'm going to find out what that's all about. And so what Perry did was to soak retraction cords. Now, what retraction cords are ordinarily used for is when you do crowns, you pack some string around the preparation so you can get a good, accurate impression of the area that's just slightly subgingival. And so you use strings in order to be able to pull the gum tissue back. The strings have some kind of a chemical in them to help the gum tissue retract a little bit. What Perry did was to take that and he would soak the strings in citric acid, and the hygienist would pack the strings around the gum tissue and leave it there for about 5 minutes. And then he would pack the string, then he'd take those strings out and he'd take another set of strings and pack them under the gum tissue. And this time the strings were soaked in tetracycline. So now the gum tissue is reflected back, and the hygienist would do their work. And one of the hygienists who worked here at that time, Barbara Miller, and I went down to Scottsdale, Arizona to watch what they did in their office. And sure enough, I saw him doing it, or saw the hygienist doing it, and I saw the end result. And so, yeah, citric acid, tetracycline, I should have pushed, okay. And so what I did was come back here, and we went at a Christmas party in 1987, which was at the Strawberry Mansion, now called the Mansion. We were upstairs, we were in the third floor in the attic. There was a little mouse running around while we were having dinner. And I announced to the group that we are going to do nothing but non-surgical periodontal treatment for the next year, and we're going to observe what the healing is like. And Rebecca said,
Our Christmas party is going to be at McDonald's this year.
And you meant it.
I meant it.
So the deal was this, okay? Everybody was getting periodontal surgery. I said, okay, we're going to go for a year. We ended up going 8 months, and we're going to do nothing but non-surgical treatment. We're going to charge surgical fees for non-surgical treatment. And if the person needs surgical treatment, I'm going to do it at no charge. That's the way it worked. Now, we carried out only for 8 months, but only 4 patients needed periodontal surgery. There were no implants at that time. I was a periodontist. We were busy practice. Only 4 people needed periodontal surgery. It gave me the opportunity of understanding how healing could progress with minimal intervention. Now, how many people want minimal intervention? Like everybody? You know, now you've got endoscopes that go into guts, into knees, and all that kind of stuff. That wasn't around at that time. Minimal intervention. And so when I saw that, and only 4 patients needed periodontal surgery, I'm already giving you the end of it. I want Rebecca to give her impressions as to what occurred during that time, from the moment of the party to and you can face the audience, because we want you on camera.
Well, first of all, I got to go to Scottsdale with you and Barbara.
Oh, did you go there too?
I went there too. I did.
Okay.
And when we got back, that's what he said we were going to start doing. And I was very hesitant about that. One of the good things that was about the citric acid and tetracycline cords is it opened up the tissue. So you could look right down on those roots. Now, before that, you did your root planing in general, so the tissue was floppy. You could do that. And so you couldn't see all the places like with the endoscope, but you could do so much of a better job. And that was great. Now, he's getting a little antsy. Thank gosh they came out with implants, because that got him on another trail. But the whole deal here, and being a hygienist and getting to work in a periodontal office is the highest you can get. And I thought I was really good when I got out of school. I learned a lot of lessons. You know how to hold the instrument, you know what the instrument is, till somebody takes their time and teaches you to how to use the instruments, how to use everything. And that was Dr. Sheldon. Back then he had extra time. Spent it in my room. That was good. I mean, and I have to admit, sometimes I'd go back after work and cry in his office, and he's just pat me on the back, and off we went. This was just amazing to see people heal. It really was. At that time, we babied them. We would polish them every week and a half till we hit 6 weeks. And of course they look gorgeous because we babied them. But it was so amazing how people can heal if their body is okay, if you have an uncontrolled diabetic or something like that, that's not going to work. But that was just amazing. And should we go to the endoscope?
Yeah, let's go to the endoscope. So we move on. So this now is 1988. And so we carry that out, and Rebecca carries that out, and we observe what healing occurs. Now we come to the year 2. And again, Rebecca developed that program. So Rebecca, talk about that.
Okay, it was amazing what you could see. But it's a trial and effort. It's a trial. It took time. You couldn't just do it one time and say, I give up, because you had to keep at it. I had to go to Dr. Sheldon and say, I need more time for some patients because I can't get it. I know it's there, I see it. So you get, stop. Or it's been a pleasure to use that. Our first one we had, it was like black and white, but it was great, it was. Then we got the next generation, which was like a color TV, 4D, it's just like, wow. And but it still takes time, and you can't give up on it. And some patients are easier to work on than others. Sometimes it's faster, sometimes it's slower, but it's just made the healing so much better. So the areas that we still have bleeding in, maybe still have some calculus, or they need some surgical intervention. So,
I think the important part of this is the fact that it takes time, it takes discipline, and it takes skill. And there are very few hygienists who can pull this off. And so, and we're going to talk about this, and we're going to go into detail in a second, but understand that when somebody says to you, I can get it cheaper someplace else, there's a big definition of what it is. It has everything to do with the quality of the individual who's doing it. Perhaps the technology is a good assist, but it is the quality of the individual who's doing it, who can get it, and who can get the result. And that's where we're going to go into detail. But understand that Rebecca pushed through this. This wasn't easy. When I owned the practice, and many of you were around when I owned the practice, although you saw me on my way out, but when you saw me on my way in, I was kind of strict, maybe. It had to be done right. I was talking with Jennifer yesterday, and yeah, was I involved in Jennifer's front desk training? And the answer was yeah, I was. It was just the way it was. Danielle too. I mean, everybody. There are certain things that you have to do, and so when you see that the doctors are saying, "I want this," they want it because they want the best result for the patient. We're not just playing, okay, we're the best dentists in Brevard County over the past 10 years. We really are. And we are because of the people that we hire, and then what we insist on from the people that we hire to move from here, which was already good, to here. And Rebecca was the forerunner of that and was able to create a system so that most people who have periodontal disease don't need periodontal surgery, don't need anything other than good, thorough perioscopy, if you want to call it that, or endoscopy, if you want to call it that. But that gives credit to the scope, and it's really credit to Rebecca, and now to Morgan. So understand that that's where we were, and that's how we got there, and that's how we are unique, don't say weird, unique among practices. Let's see what's showing up here. Later on, we started to develop the OralDNA test was developed, and understand during that time, during that early period, we were trying to find out what bacteria was growing within the pocket. And we would take cultures, we put paper points inside the pocket. So the pocket, you just put a paper in there, you'd put it in a culture medium, and we'd send it up to the University of Florida in order to be able to determine what bacteria was growing there. I wanted to know that because there's some people who have aggressive organisms. We were sending it to other laboratories as well, and we got varying results. And in the literature, we got varying results. And part of the reason for it is by the time the bacteria, which was in that culture medium, was sent up by FedEx to the University of Florida, that bacteria would die. And so I wouldn't get an accurate report. And that was until OralDNA came out. And with OralDNA, I was able to get an accurate representation of the organisms that were there. What I feel is a landmark paper came out in 2020, and it's called The Reevaluation of Scaling and Root Planing, and understand where the orientation is. We really aren't talking about scaling and root planing that much. You know, it's assumed that you're doing scaling and root planing. Oh, everybody knows how to do scaling and root planing. And so Dr. Charles Cobb and Dr. John Sotosanti went back and they looked at root surfaces to be able to determine the importance of scaling and root planing and getting roots prepared properly. And so they were looking at the diagnostic end, and let me show you what they found. Okay. Okay, number one, surfaces of subgingival calculus. Subgingival means below the gum line. Calculus are covered with a biofilm. That's a bacterial film that's of metabolically active bacteria. So this calculus has bacteria within it. And the periodontal inflammation is clearly related to the presence of that calculus and biofilm. So for those who are relying on testing, let's look at the root surface first. Let's understand what's on the root surface and do what we do best, and that's to prepare root surfaces. Okay, current evidence suggests that inflammation associated with periodontal infections affects both the immediate and the oral environment and the patient's systemic health. And so now we're bridging from we've got an infection in the gums, and now it's bridging to other areas of the body, which many of you are aware of. And finally, it requires time, exceptional skill, and perseverance, and patient compliance to get the result that we want. Time and exceptional skill. Exceptional skill. Let me show you a little bit about that bacteria. Okay, so now this is the root surface of the tooth, and what you're seeing is the root surface, and you're seeing calculus right there. Oh, I already drew it in. All right, good. So let's take a look at this sample right here, and let's look into the calculus. And what you're looking at is spaces between the calculus. So picture a piece of Swiss cheese. And this is, you're looking at the hole within the Swiss cheese. So there's the hole. And what I'm going to do is locate for you all the bacteria within this small hole that you could not see with your naked eye, couldn't even see with a regular microscope. This is an electron microscope. And there's bacteria within those spaces. Unless we get that calculus off, that bacteria remains. You can't just smooth that calculus off, because as you smooth that calculus off, there's still holes with Swiss cheese in it and still bacteria within it. Let's look at an area of calculus. Now what you're going to see to the right side of your screen is the calculus. That's the calculus there, okay? I just colored it so you could all see it better. And on the left side of the screen is the root surface. And I want you to notice right here what's there. A little finger projection. Essentially what's happened is the calculus has eaten out a space. The calculus actually drilled a little hole into the tooth so it engages into the root. It's holding on to the root real well. So here's Morgan, and Morgan goes in and she says, okay, I've got this tooth. I'm going to go in there, and I'm not saying this is Morgan. I'm going to say any hygienist, not Morgan. So there she is with her Cavitron tip. And she goes in with her Cavitron tips, just zzz, 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 zzz. And what happens? Oh, a piece of calculus flies out. Oh, am I happy? I got it. Oh, I got a big smile on my face. Except what's really going on is this. Bzz, 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 bzz. Gets loose, comes out, zzz. And look what's left. That's fractured calculus. In other words, the calculus doesn't come off the root, it breaks within itself and always leaves, or almost always leaves, residual calculus in there, which has the same Swiss cheese opening, which has the same bacteria, which has everything that's bad. So now you look with the scope, and now Morgan discovers, I'm picking on you, why not? Because you came from one environment and you moved to this environment. And I bet you, Morgan, when you started, you weren't sure this was the right environment for you, right? Okay, maybe. That had to do with the environment that you came from, okay. So, but it's discipline, and take a look what happens. So we have this fractured calculus. Now Morgan tries to do the best as she can, or any hygienist tries to do the best as she can, and she goes in there with a curette. And she engages the calculus, and she pulls up, and she gradually removes what she thinks is the more calculus that's left there. And she smooths the root and even tries to get rid of that finger and gets rid of that finger along the way and does root planing. Except what remains? The fractured calculus is still there. So now she goes in with a scope. And now she can discover with the scope what's there. And now either inspecting the scope with a two-handed technique or with a single, all right, now I know where this calculus is, now let's go and get it off. Then she comes in and then she removes the calculus. She'll start with an ultrasonic scaler, and then she may move to, and she'll likely move to a hand scaler. We want to do ultrasonics as much as we can. Not that ultrasonics will do the complete job, it won't. But at least we're doing the bulk of the work with the ultrasonics, which is easier on the fingers. But then she goes back in and she still sees there's some residual calculus left. There's always residual calculus left. We're trying to reduce the concentration of the calculus enough that the body will heal, but because of those projections, those finger projections that are in there, there's always going to be a little bit of calculus left. Our goal is to reduce the calculus enough that the patient will heal. Just as when a root canal is done, what they do is go inside the root, go inside the canal, and they clean the canal as well as they possibly can. The cleaner you get the canal, the better the healing is going to occur. You're never going to get to 100%. It's what's the critical concentration of bacteria they need to remove in order for the body to be able to fight the infection and to be able to reform bone on an abscess. And that's what an endodontist is doing. Okay? And just as we have better dentists than others, we also have better endodontists than others, we have better hygienists than others, we have better plumbers than others, we have better assistants than others, we have better everything than others. Okay? In these days, we try to make everything equivalent. Everything is not equivalent. If it were equivalent, I was going to say I'd be doing something else, but I am doing something else. In, when was this? In 2017, the American Academy of Periodontology and the European Federation of Periodontology got together and came up with diagnostic criteria for periodontal disease. So, this was produced in 2018, the work was done in 2017, and they started to stage and grade periodontitis much the way you would stage and grade cancer. Okay, whether that's a good idea or not, we can debate that, but that's what they did. But so essentially what they did was come up with a classification of disease. What's the diagnosis? Didn't talk about treatment at all. They talked about diagnosis, stage 1, stage 2 is worse, stage 3 is worse, stage 4 is worse, grade A, B, and C, how fast is it progressing? And that was that, but there was no rationale for treatment at that point. So a group of doctors got together and they said, hey, all right, we've got this classification of treatment, what do we do with it? And so the group came up with this little flow chart. Now it's going to be difficult to see the flow chart, but if you take a look at the left side, you've got periodontal health up here, stage 1, stage 2, stage 3, stage 4 periodontitis. You come up with a treatment plan, and then the most important part is to reevaluate. And when you reevaluate, what you determine is the patient under control or not? If the patient is under control, great, you go into recall. If the patient is not under control, then they need more advanced therapy. And this was the rule that we gave, that we're broadcasting to everyone. And we've published now 5 papers on this in different dental journals. The idea is that there is a difference between health and disease, and there is basic treatment, and then there's advanced treatment. Now we're a periodontal office. We do advanced treatment right from the start. And that's using the perioscope or using the endoscope to get in there and get the root surface as clean as we possibly can. Why? Because we know that a hygienist, if a good hygienist, given all the time in the world to scale a tooth, can predictably get a tooth clean only 4 millimeters below the gum line. Can't do any better than that. How do they know? They gave the hygienist, they said, all right, here hygienist, spend some time with the patient. I want you to clean a patient's teeth as well as you possibly can. They're going to be extracted for dentures anyway, so we can then look and see how well you do. And so the hygienist took 35 minutes per tooth to clean the tooth. Then they extracted the teeth. They looked at them under the microscope, 4 millimeters. 5 millimeters, a bit of a crapshoot. Beyond that, 6 millimeters, you weren't getting the root surface cleaned at all. That's what was found. That's the importance of the endoscope. That's the importance of the skill level of the hygienist and the willingness to actually look at that scope. Magnifying that root 40 times and seeing something you'd never see with the naked eye, even in that retraction cord technique that Rebecca really liked and really did well with. She was still looking with the naked eye, or maybe with loops at 2.5 or 3 power. Here, when we're putting that scope down, 40 power. Boy, is that humbling when you look at the root and you see it magnified so much. Am I ever going to get that root clean? Well, we know we're not going to get it 100% clean. We're just going to keep on going and keep on going and keep on going until we have a clean, smooth root surface so the gums can snuggle right back. And we can regrow some bone that might be lost, which happens not all the time, but it happens in some cases. So there is this idea of this, everybody's heard about Perio-Systemic, right? And that periodontal disease is related to heart disease and cancer and Alzheimer's disease and things like that. And some people are saying that's really, 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 really important. In fact, there's one ad that says up to 50% of heart disease is caused by periodontal disease. I don't know that that's true, but that's what they're saying, okay? And it's not true. And so what we want to do is not go so far as to hype it, but we certainly want to emphasize that that periodontal disease has everything to do with overall health, but a lot of things do as well. So in this paper, which was published in 2009 by some very, very credible people, that periodontitis increases the level of systemic inflammation. It's one of the things that increases the level of systemic inflammation. And the bacterial species found predominantly in the periodontal pockets have also been found in an atheroma, which is in a blood clot in the heart. Okay, so they looked in the heart and they found the same bacteria that only are found in the mouth. And so there's a relationship there. I want to bridge the gap, association and causation. If they're associated, that's one thing. That doesn't necessarily mean cause, and we're saying, you know, it might be not might be, it probably is one of the causes of systemic disease. What else? A direct causal relationship between periodontitis and atherosclerotic cardiovascular disease is not established. That was in 2009. Okay, in 2021, again, this is published in a medical journal. And it says there is a link between periodontal disease and acute cardiovascular disease. There is a link. And the evidence from epidemiological studies shows that the odds ratio of atherosclerotic disease, heart disease, is greater in patients with periodontal disease compared to non-periodontal disease individuals. So it's important, okay? They're recognizing that. And the impact of periodontal disease on the initiation of acute cardiovascular disease is not clear. So still, we know there's an association. We're finding the bacteria that are only found in the mouth, and we're finding that in the heart. We're seeing that. It's how much does that contribute to the disease? And you're going to then go to theory. And so there is an author who's talked about the fire. So let's talk about the fire and all the things that can cause the fire. So donuts can cause fire. Okay, we've got alcohol. That can contribute to the inflammation. That's what the fire is. Smoking, that can increase it. Okay, snoring and restriction of airway, that can increase it. What else? So we covered the other thing, and there's periodontal disease I put in there. Did I miss one? Yeah. Okay. And these are all of the diseases, the inflammatory diseases, and there's more than this, that can affect it. Whether we're talking about heart attacks, whether we're talking about arthritis, whether we're talking about breast cancer, whether we're talking about chronic obstructive pulmonary disease or inflammatory bowel disease, all of these are the products of inflammation. And the more you reduce the inflammation, the better the patient is going to be. So treat the periodontal disease. The inflammation will go down. Get the diet better. Stop vaping. Stop smoking. Stop the alcohol. Stop the donuts. And you're going to reduce the entire inflammatory condition down. We're experts on teeth. That's what we know best. But we cannot ignore everything else that's going on in the body. We're also healthcare providers. So if we know that approximately 42% of people in the United States between the ages of 30 and 79 suffers from untreated or inadequately treated periodontitis, you want to talk about a pandemic?
Oh, yeah.
42%. Now that doesn't include the gingivitis people. You know, by the way, we have no link between gingivitis and periodontitis. Do you know that? Most people don't know that. There's never been a link found. People will say, well, you get gingivitis, it's going to become periodontitis. Even when I draw that little diagram, I say that too. We don't have a link between gingivitis, which is inflammation of the gum, and periodontitis, which is the loss of attachment, loss of the ligament, and loss of bone support around the tooth. Our primary methodology of treatment in this office is the properly prepared root surface, and boy, am I proud of it. And I'm proud of you. That's what we do, and that's what we do best. And we don't move from that to all of the other things until we have that done really, really well. Our treatment principles in this office are diagnosis first, then treatment. I want to know something before I stick an instrument in there. And so you're going to see us doing some things that may be a little bit different, our dental and medical history, and I depend on you for that. I want a complete dental examination, and you know we have a 27-point dental examination. We're looking at a lot of things. We can go into detail someday on that. Okay, I want x-rays to include a full mouth series, a CAT scan, and the interpretation. And let me give you an idea as to some of the interpretation we've got with the new CT scan that we got last year. We're not looking at teeth there. What are we looking at? I'm looking at the airway right here. You see 27.9 millimeters? That person has a restricted airway. They have a restricted, but here's where it should be. Here's where it should be, up here or up here. Restricted airway. Do you snore? Yeah. Do I stop breathing? Yeah. If you stop breathing and you have reduced oxygen, do you think you're going to improve that patient's health, or is that patient's health going to get worse? And so with the CT scan, every time now we're looking at this too. Because if a patient has a restricted airway, that's disturbing their health. And with the CT scan that we're using for teeth and for abscesses and for sinuses and all that kind of stuff, all we have to do is turn it around. We do that and we see 27.9. This person is restricted. We sent her over to the pulmonologist last week. In fact, the pulmonologist called, said, I've got an opening right now. Good. Here's the evidence. Let's go see her and let's get her taken care of. Doesn't mean she doesn't need her dental stuff done, but boy, with a tube that's small when you're breathing, do you think that isn't going to be a problem in that patient's health? So, important. Okay, we do bacteriological testing and other testing. Does everybody do that? No. Is it important? That's up to the individual. That's up to the doctor is how important it is. I want to know in advance what's there. I want to know what I'm treating. And not only do I want to know what I'm treating, but we can also do a comparison, and that's why we're always now doing an oral DNA test at the reevaluation. Do I know that by reducing these bacteria the patient's better? Yes. Do I know that's the only thing? No. It's only a test that we have right now. There are going to be better tests that are developed in the future. But right now, at least I can find out that the red organisms, which are the worst, they're better. And I can see we're on the road. Now I've got to correlate that with probing and bleeding and pocket depth and make sure that the patient's getting better. So I'm only looking at one aspect, only looking at 11 bacteria when there are a lot more, and there are other bacteria that are involved that are not in this test, but this is a good test that we have. And it's been reliable for me for over 10 years, and that's why we continue to use this test. But that's the reason we need the comparison. But the other thing is that if a patient needs an antibiotic, and we'll talk about antibiotics in a moment, but if a patient needs an antibiotic, this company is great at selecting the antibiotic that's most appropriate. And it's been spot on nearly every time. And so if they say, based on this bacteria, metronidazole is good, then that's fine. Now, for most people, it's metronidazole and amoxicillin. But for some people, it's clarithromycin. For some people, it's other things. And so I like that. I like that guidance, and I think Dr. Furtado likes that guidance too. But the other thing is it becomes an education for the patient, because remember we talked about the link between periodontal disease and systemic disease. On that same chart, it goes over the bacteria you have and how that's related to cancer, cardiovascular health, joint and musculoskeletal health, dementia and brain health, metabolic health, and pregnancy. So the patient can now look at this chart and say, all right, I got it. I got to get my act together because this bacteria is at least related. We don't know how causally, but at least it's related to some of the other things that are going on. So it becomes an education tool for us in the chair when we're working with the patient, or for the patient to go home and to read it, him or herself, in order to be able to see exactly what they're dealing with. We're very much of the opinion that we've got to reduce the amount of antibiotics that we're prescribing. And so we're tending to reduce the antibiotics. Why? Because in this study, antibiotic resistance to penicillin is 40%. Okay, so if we're giving an antibiotic and the patient develops bugs which are better than the antibiotic, how much are we helping the patient? And so we've got to be really judicious, really have to think about whether we're going to prescribe antibiotics or not. You're seeing us prescribe fewer and fewer antibiotics because we want to see how this single treatment will work and not expose somebody to antibiotics that may not be necessary. Oh, well, antibiotics mean nothing. When I grow up, hey, take some antibiotics, it's fine. No, it's not fine. Everybody's talking about the microbiome now, okay? The level of bacteria and the association and the family of bacteria that occupies our system. And as soon as we give an antibiotic, we're screwing up that family of bacteria. And it can take months and sometimes years for that family of bacteria to come back to normal. And that's called commensal bacteria, bacteria that is working well for the body. Okay? So we got pathologic bacteria, which is the bad stuff. We've got commensal bacteria, which is the good stuff. And what we're trying to do is not disturb the commensal. And the question is, can we get rid of the pathological bacteria just by going in and doing good scaling and root planing? Just by going in and doing the endoscopy and identifying that, is that enough? Because you saw where the bacteria is, and there's bacteria within the calculus. That's sufficient. Now, this company happens to have a number of different tests. There's a genetic test, they have a candida test, they've got a caries test, risk for bacteria. They even have a viral test because there's some viruses that have been proposed as causing periodontal disease as well. So this company is a company that we like for that reason. Okay, and then the next part of it is complete treatment planning. Complete treatment planning so that when a patient is seeing us as periodontists, we're not just acting as periodontists, we're acting as full treatment planners, and that's why everybody comes through with a complete treatment plan from start to finish. We happen to have some real talent here in Dr. Matt. And so he can perform and he can give a patient good treatment. But even before Matthew was here in the practice, I always did complete treatment planning. Okay, it was always, all right, it isn't just the gums. You know, it's what's the bite like? How are the teeth meeting? Where's the decay? All of those types of things are important in the patient's overall health. We can't just focus in on that one area. And by the way, we pick specialists for those reasons as well. Notice, the older I get, the more opinionated I become. I can get away with it at this age. I want to see this person. No, you're going to see this person. And this is the reason why. I get great results with her, with him. That's why you're going to see that person. Because remember we talked about at the beginning, exceptional skill, exceptional skill, exceptional skill. So in our periodontal treatment planning, we do the dental and periodontal examination. We detect a rough root surface, which Rebecca thinks I know something about. Morgan did not have the benefit of being beaten up by me. Maybe she can be beaten up by Dr. Furtado and Dr. Matt instead. But, you know, Rebecca, what's it like when what was it like when I put the probe in the mouth when I would be doing a reevaluation? You want to discuss that a little bit?
The first thing I would worry about, well, I already knew what the pocket depths were. First thing I would worry about is that you were going to ask for 11, 12.
That's a curette.
A curette or anything. That's where he thinks it isn't smooth enough. And then you hold a piece of cotton out there for him and you pray. And either he'll find something or not. But if it's there, it needs to be out. But exceptional exams, and when he was finished, I'd go, whew, okay, we've done another one. But you have to have somebody looking over your shoulder, especially in the beginning. You just have to, because as you said, you know, the examination and the re-examination are so big. It is so big.
Okay, we identify the pathogenic organisms, and right now we're using the oral DNA test. We use an antibiotic assist if necessary, and that if necessary is becoming more and more of a problem. You know why we prescribe antibiotics so much? Because if a patient gets an infection, they come back and you say, well, you didn't prescribe an antibiotic? Yeah. There's no science there. They probably would have gotten the infection anyway, even with the antibiotic. And so, you know, we're playing defensive dentistry, if you will. Oral hygiene instruction, extremely important. And we have our own periodontal, removal of all calculus. And you know there are limitations to that, but boy, we can do a real good job of removing calculus in this office. And then modification of the adverse health factors, and we can go into that for a moment. When a patient comes in, they have this kind of a level of awareness. Number one, they come in and they start confessing. I've neglected my teeth. And then they realize they may lose their teeth. And then they want to get them better. And they're willing to make changes to make their oral health better. And then once they've done that, maybe they're willing to make some lifestyle changes too. And then they're willing to do them. And then they're willing to get outside help to improve their overall health. That's what they're thinking about, but they only think about that usually in that order, in my opinion. Now we have to increase the host resistance, which means we have to increase the body's ability to fight disease. And so that's where the smoking, alcohol comes in, the diet. And we're recommending this book, Eat to Live, by Dr. Joel Fuhrman. This is the first book he published, but what's good is he has books on every disease. Now the principles are the same. The end of diabetes, superimmunity for people who have immune function problems, autoimmune disease, the end of heart disease. And so you can take anything that resonates with a person and you can get a Joel Fuhrman book, and if you get Eat for Life, which is the most recent book, that's a summary of all of them. But if the patient says, I got heart disease, my doctor says I need to be on this medication, well, you do need to be on that medication. What else can we do to reduce the risk factors in order to be able to get you better? Which, by the way, will reduce inflammation, which may help you in your periodontal disease as well, because they're all tied in. Okay? We're going to use probiotics. We use probiotics, which is something which asks bacteria into the system, good bacteria into the system when we prescribe antibiotics, and maybe even more than that. And there's something called nitric oxide. Nitric oxide is not nitrous oxide, not the stuff you breathe in the dental office. Nitric oxide, which actually is produced within the airway. And if you have nitric oxide production, nitric oxide will increase the width of your blood vessels. If it increases the width of your blood vessels, your blood pressure will go on. So let's talk about people who are mouth breathers, who don't get the advantage of getting the air through here, through the nose, and getting nitric oxide. Then we want to increase their airway. We may want to send them to ear, nose, and throat to open up their nasal airway. The easiest way to get a person who's a mouth breather to be a nose breather is put tape over their mouth and when they're sleeping, and let them sleep, let them breathe through their nose. If they suffocate, you know there's a problem. But the other thing we can do is prescribe a nitric oxide supplement, which we may start doing. We haven't had that discussion yet, but this is the supplement that I've been taking for the past 6 years. I measured my blood pressure last week. I don't take my blood pressure medication. It was 109/75. Okay, and then medical referral is necessary. That's the way we work in this office. These are the systems that we're all adopting together. And as Dr. Matt, Dr. Furtado, and I get together, we're developing these systems more and more. So you know things are changing. They only change gradually, and you latch on to the things that have worked well for us. Any questions?
I want to follow up that a little bit. You have the mic? We use a lot of initials in this office: MVF, KLD, RSC. Over the past, I guess my whole life, I'm going to start calling him SOT, the seeker of truth.
Wow.
Because you come in, you know, how many times has a salesman come to your office the past 40 years? They've got their narrative that they're going to come in and try and sell you, and there's probably that much truth to the narrative. And so if we can find the greater truth, there's a lot of products out there, there's a lot of BS out there. Some of you have been in corporate offices that take every insurance under the sun. They're losing money when they come in for just a cleaning. So what is the dentist and the hygienist looking for? Any way to make money. Let's stick some Arrestin in the pocket of a 4mm pocket rather than remove all the calculus. When I come in for a dental examination in a hygiene room, I'm hoping I don't find anything. What do you think that dentist is hoping to find in a different office? They want to find everything. They're looking hard for anything and everything. So seeker of truth. That's what I'm getting from all of this, and I hope you all can appreciate that too. So thank you.